Hi, Dr. Paul Corona here. I've been getting a lot of comments. I'm on. If you haven't been on my social media, I'm on Instagram and on TikTok. So yeah, if you want to join me, my social media is really growing, and I'd love to have you join me. We do a lot of like quick videos, like 90-second videos. A lot of comments, a lot of hate comments at times. People who get angry about my, stance on medications. I get a lot of positive comments about, I've been these medications have changed my life. I've seen that, but I see a lot of confusion about people who think they know about the science, or they think that there's nothing. I've heard say there's no such thing as chemical imbalances, and that's all fake. That's fake science. No, it's not. There's plenty of science to back this up. But I think a lot of people get their advice. They look up social media, or not social media. I'm sorry, they look up the internet. They Google it. They find a study from somebody who's a medication hater, and then so they read this thing about someone who has these alternate views, which are not true, and so there's a lot of that. People get information from different sources, from friends, family, who get them, where they don't really understand the science of what's going on. The biggest probably comments I get are about SSRIs. So SSRIs are the most basic medications I work with. Basically the first modern antidepressant is Prozac back in the mid '80s or so. Now we have 8 of them on the market. We got Prozac, Zoloft, Paxil, Celexa, Lexapro, Luvox, Vibrant, and Trintellix is the newest one. So we got 8 of them on the market, and they stand for, again, selective serotonin reuptake inhibitor, inhibiting the reuptake of serotonin. So what's the problem? The problem is that the chemicals are supposed to be going this way, and the problem, and if that's not happening, and they're starting to go that way, that's the problem. So these are supposed to be one-way transmitters. These little holes that the chemicals travel through should be going this way, not that way. But the problem is when they are leaking, they start to go both ways. And then I got a comment about, oh, you're talking about leaking. You're a doctor. You talk about leaking. I say, yeah, well, it's leaking. That's what they're doing. So basically, inhibiting the reuptake of serotonin, it means it attaches to the serotonin. It blocks that, and so that serotonin then has to move forward. And then it reconnects to the next cell. And then it kind of just keeps going that way. That's good. The problem with SSRIs, they can be good for some people. Some people get no side effects. They get only benefit. And I have some people that are on an SSRI, that's it, and it's perfect. That happens. More often than not, it can help, but then it can give you problems. So the biggest problems and the biggest complaints I hear on social media are the sexual side effects, which, more often guys complain, and women do too, but more often it's guys. Apathy, so people feel like I just have no emotion. I feel numb. I feel apathetic. I feel like just emotionless. But some people say, but I prefer that to feeling constantly anxious and nervous, so at least I'm feeling better. So a lot of people feel like, I like certain things, I don't like other things, but I'm kind of feeling like, what choices do I have? Well, you do have choices. You have plenty of choices. You're not stuck with one thing. If it's not the right thing, we can change it. But let's say it's just okay, but not great. I'm a big fan of SNRIs. I think they're not all the time, but maybe 2/3, 3/4 of the time, SNRIs are better than SSRIs. So again, serotonin, norepinephrine, reuptake inhibitors. Okay, now we're getting to norepinephrine. So why is that better? Because sometimes just working on serotonin alone, is going to give you the side effects. Because if you don't pay attention to these other neurochemicals, you're going to get benefit but side effects. So sometimes I switch to SNRI to see if it's better. Sometimes it is, sometimes it isn't. It more often is. And norepinephrine is related to anxiety and pain. So the reason the SNRIs are better, they're more complete because they not only help with depression, but they are better for anxiety than SSRIs, and they are better for like pain. What pain where? Neck. So number one would be here: neck, shoulders, upper back. Most people can relate to like tension of that area when they're stressed. Headaches, back, neck, like stomach pains, fibromyalgia, irritable bowel. So there's a lot of things physically that could happen, and a lot of times SNRIs can help that. Let's say they don't, and let's say someone doesn't tolerate that, but they do tolerate the SSRIs except for the side effects I just said. Then what? Well, that's where I add Wellbutrin. So Wellbutrin is really an amazing medication. I prescribe a ton of it. So that's an NDRI. So it works a little bit on norepinephrine, but it's really focusing on dopamine. And when you boost dopamine and that connects to the next cell, motivation, energy, drive, sexual, basically side effects going away. So sometimes what I'll do is I'll combine one of these two, or an SNRI, with Wellbutrin. The Wellbutrin takes away the side effects. The apathy goes away. You have more motivation, drive, sex drive comes back, sexual function comes back, and it's focus, happy, positive. So that's really more for depression. Wellbutrin doesn't help anxiety. If anything, it can make it worse if you use it by itself. It's usually better when you add Wellbutrin to something else. Not every person. And some people, serotonin or norepinephrine are not issues. And so sometimes we find out with trial and error that they don't do well with an SSRI, they don't do well with an SNRI. Okay, if that's the case, well then I throw those out. Okay, well it's not those chemicals. It's got to be dopamine, or it's got to be GABA or glutamate. So by trial and error, I'm able to kind of figure out that what's happening here. And if it, again, the thing to remember is you're not stuck with something. So when people say, oh, it's causing, okay, well, we can stop it. We can always have the option of stopping it and starting over, trying something else. So you're not stuck on things. And when side effects go away, and if side effects are caused by a medication, you stop the medication, it goes away. So it's not that big a deal. But people make it a big deal because people get angry about it. And unfortunately, I'm doing this video because, I think there's a lot of people who give up, a lot of people who think there's such negativity about these that they're never going to give it a try. And I'm hoping that I can change minds and say, look, maybe I just need to try again in a different approach. Maybe I need to see a different doctor who knows more how to do things better and whatever. But not to give up hope, because there is hope here that if we get this done correctly, you're going to feel great. And so the goal, and I tell people, I want everyone to have anxiety under control, depression under control, good energy, good motivation, good sleep. Everything should be clicking if we get these right. So that's the main thing I want to discuss, is this whole issue with SSRIs and the confusion surrounding them. The fact that they are really good for certain patients. I have a lot of people on them. I have more people on SNRIs, but I still have a significant amount of people on SSRIs. Why? Because they work. And sometimes I switch to SNRI and it's not tolerated, or it's just not the right fit for the person. So then I go back to the SSRI, and then we have to deal with, okay, we get the benefits from that, but we need to deal with the side effects. And it's not just a matter of putting another thing on just to deal with side effects. That's not the point. The point is basically completing what we started. Because if you balance this and this is out of balance, dopamine's going the wrong way, you're not going to get the complete results. And then you're going to be still, again, tired and low motivation, low energy. And Wellbutrin can easily fix that. And again, if it's a little bit more complex, like a bipolar situation, then we need to deal with different medications like mood stabilizers. So people and so antidepressants alone sometimes are to get people only so far, or sometimes they make them worse. So if antidepressants are making people worse, then we need to reassess the diagnosis. Maybe the person's bipolar. Or if antidepressants are causing suicidal thinking, okay, well, that shouldn't be happening, even though you're going to see this. And again, the other thing people comment about is that these cause suicidal, and you're going to see that a lot if you read about it online, and it's just not really the truth. Antidepressants save lives if it's depression. Now, if we're dealing with depression, we're dealing with anxiety, they're life-saving. If we're dealing with bipolar disorder, you have to diagnose it correctly, because there's a possibility with bipolar disorder that an antidepressant can make it worse. So if an antidepressant is causing suicidal thinking, you yank that away right away and say, okay, well, I have to rethink this, because I'm probably not going to put him on another antidepressant. I probably have to think ahead and say, okay, I'm going to put him on a mood stabilizer, and working on basically, instead of pushing things this way, sometimes things are going too fast this way, like in a bipolar situation. It's like dopamine is just flying through the brain. And then we put a dopamine antagonist down there, it just slows that down. And when you slow down dopamine in a bipolar patient, it also helps with anxiety, and it gets rid of anxiety. And it gets rid of the racing thoughts. And so now, what are those? I mean, there's a lot of them on the market. You might have heard about risperidone, Abilify, Zyprexa, Seroquel, Rexulti, Vraylar. These are some newer ones, and you're going to see some on TV. So these are also very good for depression. They're good for anxiety, but they're basically a different level, because we're dealing with a different situation. And sometimes the bipolar situation is not so obvious. It's not always mania or and irrationality. It's sometimes just really, really tough depression that is just not getting better with antidepressants. So whenever I have a person on antidepressants, and let's say they help, but they only get people so far, and that's it, that's not good enough. So what that's telling me is that there's a deeper level, or what we call a bipolar depression. And you can have bipolar depression completely separate, with no mania, no hypomania, none of that upper pole, we call it, because it's just the depression is so significant. But that's why sometimes these medications can really resolve that quite well. And then, again, going to GABA, we got Lamictal, we got Topamax, we got gabapentin. And those Lamictal can help with depression, the Topamax and gabapentin help with anxiety. So if you get everything done correctly, we either move GABA forward, and that really helps with mood. And so it's just really a matter of being able to read this. We always do one thing. I always just do one thing at a time to figure out one thing. And every step I take, I'm looking for more and more improvement until we get to our goal. And the goal is the person's completely better. And it takes a combination. Most of my patients average 2 or 3 medications to get the right. Some like 4 to 6, sometimes more, sometimes 1 medication. That sometimes it's really easy. So, but anyways, I wanted to kind of hopefully clear up some confusion people have about this whole subject, especially the SSRIs. Like I said, I think I'm hearing a lot of comments about them because that's the one. Those are the class of medication people have the experience with, because that's what almost every doctor starts with. Not me. But most doctors feel that that's the first line for everybody, for everything. And the problem with that thinking with doctors is, when you put something on that's going to give potential side effects, unless you keep in close contact with the patient might say, forget this, I'm not going to take this. So that you lose that person to treatment, and then that person, you never see him again maybe, and then that person might be suffering the rest of their life without getting treated because they had a bad experience, or because they tried something that didn't work. And so it's really important to get this right. And it also is important for doctors to keep communicating with people. And I think too often doctors don't return phone calls or don't check up with people. With my practice, I'm very much available. I check in with people often to try to keep things on a stable level. But again, that's why I think a lot of times the SSRI confusion comes in, because maybe it does help, but they're focusing on the side effects, but we can fix that. Or maybe they shouldn't be on SSRI, they should be on something better. like Prestige, Effexor, Cymbalta, which are the SNRI class. So anyway, I just want to, hopefully that's going to clarify things. It is real science. It's not fake. You know, you're going to see a lot of people out there who believe that. And how do I know it's real science? Well, because I know what medications do. I've been doing this for a long time. If it was fake, these medications wouldn't work. You know, because these medications only work if there's a problem with transmission here. If there's no problem here, they're not going to do anything for you at all, or they just give you side effects with no benefit. So if you read this correctly and treat the person correctly, it's really it's pretty quite easy actually to get people there if you just take the time to listen to people and really understand them. And you got to get the right diagnosis. Obviously, if you don't get the right diagnosis, you're not going to get the right treatment. So anyway, but that's hopefully that clarifies things. If you have any comment about it, please feel free to get a hold of me if you have any questions. But hopefully that clarifies the whole SSRI issue. Thanks for listening.